Right now, we're making a quiet trade-off in clinic that may be costing lives. We reduce antifibrotic doses to keep patients on something, but new data suggests that for some patients, that compromise may carry a measurable mortality signal. In the next few minutes, you'll walk away with 3 practical upgrades: how much adherence matters in IPF, how to spot a hidden musculoskeletal phenotype in bronchiectasis that predicts next-year function, and a clear, physiology-grounded way to think about temperature control after acute brain injury: what to do, what not to do, and why. 3 studies this week, all immediately relevant to bedside decisions in pulmonary and critical care. Welcome to This Week in Pulmonary and Critical Care Medicine, where we translate important new papers into clinical decisions you can actually use, without the noise. As always, this is educational content, not medical advice, and you should interpret these findings in the context of individual patients and local practice patterns. In IPF clinic, we often accept dose reductions and missed days for rational reasons: GI toxicity, fatigue, cost, and the desire to preserve quality of life. The uncomfortable question is whether those compromises are clinically neutral or whether they track with outcomes we actually care about, like survival and hospitalization. Published in Chest in April 2026, this study used a nested case control design in a large U.S. administrative claims database to evaluate how antifibrotic adherence and dosing relate to all-cause mortality and hospitalization in idiopathic pulmonary fibrosis. The investigators drew from Optum Clinformatics claims data and identified 2,425 patients with IPF aged 50 or older who initiated nintedanib or pirfenidone between October 2014 and March 2022. Median follow-up was 1.6 years, with a cohort that was older, mean age about 74, and largely male. The study outcomes were straightforward: all-cause mortality and all-cause hospitalization. For each outcome, they created matched case control pairs using incidence density sampling. That's important because it allows exposure to be defined over a clinically meaningful window, which is the time from antifibrotic initiation to the event date, rather than assuming medication patterns are fixed over years. Exposure was defined in 2 ways. First, adherence was measured using proportion of days covered, categorizing patients as adherent if proportion of days covered, or PDC, was at least 0.75. Second, dose level was determined by calculated daily dose. Standard dose was 300 mg per day for nintedanib and 2,403 mg per day for pirfenidone, with lower doses categorized as reduced and mixed patterns tracked separately. This design can't prove causality, but it does reduce classic time-related bias when dosing changes over follow-up. The main results were clinically striking. Adherence, or PDC, of at least 0.75 was associated with lower odds of mortality, with an adjusted odds ratio of 0.563 and a tight confidence interval. The adherence signal held when stratified by starting drug. Both nintedanib starters and pirfenidone starters showed lower mortality odds with better adherence. That's a practice-reinforcing message. Adherence is not a soft metric. It likely represents a mix of medication exposure, toxicity management, health system support, and patient capacity. But regardless of mechanism, it tracks with survival. Dose is where the interpretation gets more delicate. Compared with standard dosing, reduced dose was associated with higher mortality odds, and that association was most clearly seen in nintedanib starters, where reduced dose carried a materially higher mortality signal than standard dosing. For hospitalization, adherence again pointed in the same direction: lower hospitalization risk with better adherence overall, with the clearest signal in nintedanib initiators. Reduced dosing also tracked with higher hospitalization risk in the nintedanib subgroup, while pirfenidone showed less consistent dose-related associations. Now, the limitation that matters. This is observational claims data. sicker patients may be more likely to reduce doses, stop doses, or miss refills, and they are also more likely to die or be hospitalized. Disease severity is imperfectly captured in claims, even with covariate adjustment like oxygen use and comorbidity burden. So I treat the adherence finding as strongly practice reinforcing and the dose reduction signal, especially for nintedanib, as hypothesis generating but clinically attention worthy. If reduced dosing is a marker of intolerance and frailty, the solution isn't to shame dose reduction. It's to treat dose reduction as a trigger, reassess, mitigate adverse events aggressively, and re-escalate when possible. So how do we interpret this without overreaching? This is not randomization. Adherence can be a proxy for a lot: health literacy, access, socioeconomic stability, and even disease trajectory. But the design choices, time-aware exposure windows, matching, adjustment, and sensitivity analyses make the signal hard to ignore. On rounds, the takeaway is less choose drug A over drug B, and more treat adherence like a core part of IPF management. That means aggressive early side effect mitigation, rapid access solutions, and multidisciplinary follow-up, because in this dataset, staying on therapy aligned with materially better outcomes. Bronchiectasis care can quietly become airway-only medicine: sputum volume, cultures, antibiotics, airway clearance. But many of our patients struggle just as much with systemic vulnerability, frailty, falls risk, reduced reserve during exacerbations, and functional decline that doesn't show up in spirometry. Published in Respirology in 2026, this comparative longitudinal study asked two clinically useful questions. How do body composition and muscle function differ between adults with bronchiectasis and healthy controls? And can peripheral muscle strength estimate clinical status 1 year later? The cohort included 71 adults with HRCT-confirmed bronchiectasis and 92 healthy controls. Everyone underwent a detailed baseline assessment, including DEXA scan for body composition and bone measures, dynamometry for limb strength, and core endurance tests, specifically back endurance, anterior core endurance, and lateral core endurance via the side bridge test. Bronchiectasis participants were invited for 1 year reassessment, and 43 completed follow-up. This matters because bronchiectasis outcomes often unfold over years, but functional decline can be visible over months if you measure the right variables. At baseline, several findings stood out. First, bone health. Both men and women with bronchiectasis had lower bone mineral density than controls. In women, osteopenia was 54% in bronchiectasis versus 18% in controls, a threefold difference that's hard to ignore clinically. If you've ever watched a bronchiectasis patient lose independence after a fracture, this is not an academic detail. It's a downstream event that can shift the whole trajectory. Second, muscle function. Leg strength was reduced in bronchiectasis compared with controls in both sexes. The mean difference was approximately minus 25 kilograms in men and minus 18 kilograms in women, with confidence intervals that still suggest a real deficit rather than measurement noise. Shoulder strength differences were less consistent, which is interesting. It suggests the lower limb phenotype may be particularly sensitive to chronic disease burden, inactivity, and systemic inflammation. And in women, lateral core endurance, side bridge performance, was significantly worse than controls. That's a subtle but important physiologic point. Trunk stability and expiratory muscle coordination influence cough mechanics and airway clearance efficiency, which may matter more than we routinely acknowledge. The longitudinal finding is the clinical hook. The authors used leg strength as the proxy for peripheral strength and classified bronchiectasis participants as having retained or impaired leg strength using sex-specific cutoffs derived from the control group's 10th percentile. Baseline leg strength was associated with 1 year dyspnea, health-related quality of life, and functional capacity, and in regression models, leg strength explained up to 33% of the variance in follow-up clinical outcomes. That's meaningful signal for a simple bedside measurement. It suggests that strength phenotype is not just a correlate of current health. It may forecast the next year of function. We should be honest about limitations. The male bronchiectasis sample was small, follow-up was incomplete, and exacerbations were defined in a way that can be sensitive to recall and healthcare access. The data were collected earlier than publication, so treatment patterns may have evolved. And, critically, strength might be a marker rather than a cause. Patients with worse disease may be weaker because they're sicker, not sicker because they're weaker. Still, even as a marker, it's a useful one. This feels hypothesis-generating for targeted interventions and practice-reinforcing in the sense that we should stop treating bone and muscle as separate from bronchiectasis. In practice, this means consider adding a simple lower limb strength screen and bone health awareness, especially for women, into bronchiectasis follow-up, and refer earlier to rehabilitation that includes progressive resistance and core work, rather than waiting until patients are already breathless, deconditioned, and late stage in functional decline. Temperature is one of the few ICU variables we can continuously monitor and actively control, which is exactly why it attracts dogma. If we can change it, we assume we should. But this review argues for a more useful mental model. Temperature isn't a neuroprotective drug. It's a physiologic domain that can either reduce harm or create harm, depending on context, timing, and the collateral effects of trying to control it. Published in Intensive Care Medicine in 2026, this narrative review synthesizes physiology, trial evidence, and practical implementation of temperature management across traumatic brain injury, acute vascular brain injury, and post-cardiac arrest encephalopathy. Start with physiology, because the why determines the how. Temperature directly influences enzymatic reactions, membrane function, immune activity, and most importantly in neurocritical care, cerebral metabolic rate. Hyperthermia increases metabolic demand in a brain already struggling to match oxygen delivery to consumption. The injured brain has limited reserve, so fever doesn't just reflect illness, it can amplify secondary injury mechanisms like excitotoxicity, oxidative stress, seizures, cerebral edema, and intracranial hypertension. That's the core rationale for treating fever early and avoiding large temperature swings. But the review is equally clear about the other side of the ledger. Hypothermia lowers metabolic demand, but it is not benign. Cooling can impair coagulation pathways and provoke arrhythmogenic physiology, and it reliably triggers shivering. Shivering isn't a nuisance, it's a metabolic stress test. Catecholamines rise, oxygen consumption increases, and sedation requirements climb, sometimes trading one form of physiologic harm for another. This is one reason why hypothermia can work on physiologic surrogates, yet fail on meaningful outcomes. That sets up the central misconception the review corrects. If hypothermia lowers ICP, it must improve neurologic outcome. In traumatic brain injury, hypothermia does reduce intracranial pressure, but prophylactic hypothermia has not consistently improved functional outcomes in randomized trials and has raised safety concerns. The practical consequence is the modern tiered approach. Fever prevention and controlled normothermia sit early, while hypothermia becomes a later, more selective tool, primarily as a rescue strategy for refractory intracranial hypertension, rather than routine early therapy for everyone. The teaching point here is simple. Lowering ICP is a means, not an end. If the intervention adds pneumonia risk, hemodynamic instability, or deep sedation, the net outcome may worsen even while the monitor looks better. Acute vascular brain injury adds a different challenge: feasibility and tolerability. The mechanistic rationale for cooling is strong. Metabolic demand falls as temperature falls, and in focal ischemia, that's theoretically attractive. But in awake stroke, ICH, or SAH patients, sustained cooling often requires heavy sedation to suppress shivering and discomfort, which then cascades into airway protection, ventilation, and infection risk. The review highlights how this reality has shifted practice away from cool everyone toward detect fever early and treat it reliably. A key example is the Intrepid randomized trial summarized here. 686 critically ill patients with acute ischemic stroke, intracerebral hemorrhage, or subarachnoid hemorrhage were assigned to automated surface temperature modulation targeting 37.0 degrees Celsius for up to 14 days versus standard tiered fever treatment. Proactive temperature modulation reduced fever burden, but it did not improve 3-month functional outcomes, and reactive treatment of established fever was not inferior, supporting a strategy where excellent fever detection and treatment may be the high-value target, rather than prophylactic, resource-intensive temperature suppression for all. Post-cardiac arrest care is where clinicians most commonly ask, "So what temperature should I pick?" The review's framing helps. The headline is not a single magic number. It's protocolized temperature control with active fever prevention and minimized variability. Contemporary guidance supports choosing and maintaining a constant target in the 32 degrees Celsius to 37.5 degrees Celsius range, emphasizing that uncontrolled fever and temperature fluctuations are plausible harms, especially during the vulnerable period of evolving hypoxic ischemic injury. The practical challenge is execution. Consistent core monitoring, feedback-controlled devices when precision matters, and a shivering plan that prevents the metabolic cost of treating temperature. Before you go, take one simple theme from this episode. Small operational choices can have big downstream effects. If adherence support lowers mortality signals in real-world IPF, then our follow-up cadence, side effect planning, and access work aren't administrative, they're clinical care. If strength predicts function in bronchiectasis, then rehab and bone health shouldn't wait until a patient is already deconditioned. And if fever is a secondary brain insult, then temperature stability, done thoughtfully without triggering shivering harm, belongs on the same tier as oxygenation and perfusion in brain-centered ICU care. If this format helps you stay current efficiently, subscribe and leave a comment with what you're changing or what you're not changing and why. Until next week, this is Dr. Aladdin Sagar signing off.